have had the national pilot programme, which has successfully integrated 490 pharmacists in over 650 practices across England, and there will be an evaluation that I'm currently leading on with NHS England to capture the impacts of pharmacists working within this manner as well. Obviously, with all things with a pilot, we learn lots around it, and I suppose it's how we develop the next phase of pharmacists working in general practice. And we really needed to have better, clear guidances on roles, better engagement with people on the ground, application support, flexible models, but also the elephant in the room, indemnity insurance as well. So now we had the Pharmacists in General Practice Phase 2 programme. So outlined in the GP Forward View a commitment to get 1,500 pharmacists working in general practice by 2020-2021. And very much so, we've managed to have, we're looking at slightly different ways of approaching to having pharmacists working in this area, looking at innovative models that suit local circumstances. The online application portal for the funding has already opened on the 9th of January, and practices and federations are allowed to apply for this funding already. And what we will hope is that every GP surgery across the nation will be able to be supported if they're interested in this programme, in order for them to gain access to a pharmacist, also for their patient population as well. Key criteria: they must be in patient-facing clinical roles, integrated members of the team, and have a professional network and supervision support working within general practice as well. The funding in the offer is two faces really. It's sort of having a financial offer as well as education and training support for the pharmacists, as well as all independent prescribing places funded by NHS England as well to support pharmacists. So not only will you get a remuneration for their salaries or recruitment costs, there will also be another element to it around training and development that NHS England and Health Education England will be funding together in order to ensure the pharmacists are well supported as they develop within these roles as well. So just a few timelines and a few dates. Well, the first wave of applications were submitted by the 10th of February, and this application process is an ongoing application process. The application site does not close for at least 3 years. So at any time of the year or any time in the next 3 years that you are interested in having a pharmacist, that application portal will always be available for you to use. We will not be rejecting any applications as well. So we're going to be putting applications on hold that may not meet the initial criteria, and we as NHS England with our regional and local teams will work with you to get the applications to a level that is satisfactory, so we can improve that as well. The profile is to have an extra 500 pharmacists a year over the next 3 years to hit the target of 1,500 by 2020-2021. And jobs we hope will start to be advertised as soon as the announcement is made by or within April 2017. Some useful resources, I suppose, as well is good to refer to. We've added some stuff on the NHS England website around guidance, narrative, videos and case studies, state of readiness checklists for recruitment stages if practice managers are interested in recruiting pharmacists and what they need to look for, FAQs that are being continually updated, and we're doing another update next week, and link to the online application portal will be available online. For pharmacists in particular, but also for GPs or practice managers that are interested around the indemnity insurance stuff, and I'm happy to take questions after around it, I can. But also this really useful guidance from the Primary Care Pharmacy Association has standardised job descriptions that were developed with HE, the BMA, RCGP and NHS England as well as good business cases to have pharmacists working within this area. So do check out the guide, it's a really useful resource.
I'm one pharmacist in one practice. The reason I say that is there are different models nationwide. Through the first pilot, anyone could apply for a different model, do whatever they wanted to do with it, and lots of surgeries did different things. In Gloucestershire, where I am, all the pharmacists work in one practice, part-time or full-time. There are surgeries that have got one pharmacist between 2 surgeries, maybe one between 5, maybe 5 pharmacists between 5 or 10 practices. It really does vary depending on what suits your cluster or your confederation. In my practice, it was obvious when I went in that the GPs were struggling with repeat prescriptions, how to deal with them. So my morning is spent doing repeat prescription request queries, and these are the little bits of paper that come from patients, or there might be tasks on your screen about Mr. Jones is asking for something that's expired off repeat, or is something that's on acute. And I've been there for a year now in my practice, and I recode everything. I love recoding. So I know exactly what I've done. And on average per month, I've done 471, nice and specific for you. And we know roughly how long it takes to resolve one of these on average, because they may involve a phone call to the patient if it's not very clear. It may just involve a quick, reauthorising, off we go. Or it might involve calling the patient in for an annual review. So on average, about 90 minutes a day has been transferred from what the GPs were doing before to something that I'm doing every day. GPs now, if they get a discharge or a scan in that has got any medication change, they just forward it on to me, and I'm the one who implements that change and can contact the patient if any monitoring needs doing, etc. And again, about an average of 90 a month. Now, telephone appointments, all reception know, now I'm there. If anybody rings up and says, oh, I need to speak to a GP, first question is it about medication? If it is, and a lot of them are, then they get put on my screen and I can call the patient back, and that's working really well. And then not only from patients, but also from pharmacies. Might be queries from care homes, it might be queries from the hospital, just clarifying about a patient. Again, because I'm there every day, it's easy for me to pick up this work. I know GPs love dosets, repeat dispensing, batch prescriptions, 7-day, whatever you're doing, wherever you are. I have taken on that work in my practice because I know how it works on the community pharmacy side of things, I know how it works on the GP side, so a lot less is going wrong with things expiring at different times and all that sort of stuff. Medication reviews, average of 45 per month, 10-minute consultations for a med review. I do home visits for patients who are struggling with the medications, might be just on their own and not really getting what's going on. They might be on 20 different things. So in total, that's a minimum of 3 hours 40 per day of my day is transferred from GPs to me at the moment. It's probably more than that when we look at the clinics themselves. And when I did this presentation last time, one of my GPs was there and she did a quick audit before and after I started in the practice, just on telephone appointments. And before I was there, 48 telephone appointments were there for the GPs to call back from patients, and now it was 22 whenever she did that, because they're not to do a medication. And from the pharmacy or other, this is from care homes or hospitals, they've gone to 0 because they know that I'm there and I'll get it done probably quicker than the GPs because you're seeing patients all the time. What else do I do? Well, I've mentioned I'm a point of contact for the local pharmacies. They all know me. I know them, more importantly. I know what they're capable of, what services they offer, what I can refer to them or not, and they know to contact me about specific queries. I'm also there as a point of contact for care homes. We've changed the way the care homes order the medication. I don't know what they were doing before, but it was very convoluted and led to a lot of pressure when they eventually ordered it from the GP practice. Now it's not so pressured. Urgent prescriptions, of course, I'm there, I'm available, so patients coming in wanting an urgent one, I can take those on. So my clinics, I specialise in polypharmacy, being a pharmacist. I love seeing people with lots of stuff and trying to get them off it. And GPs know that and refer patients to me if they feel they're on a lot of medication that might need more time than 10 minutes or 15 minutes GP appointment to go into the real detail and look at the patient holistically about what's going on. So it's important that you know I'm not taking any work away from nurses, practice nurses. These are patients who are either not controlled or are frequent flyers that would come and see me instead. That's day-to-day work. Stepping back, strategic work, repeat prescription process. That was something that was quite easy for a pharmacist to refine in the practice. What happens from when a patient orders something to how they get the medication. How do we make it easier for ourselves in the practice? I've mentioned about asthma, looking at those overusers. Increase in electronic prescriptions, repeat dispensing. I've mentioned anticoagulation, but I also make sure that our admin team do 6 monthly audits on patients too, low TTRs and all that sort of stuff. GP updates, so training GPs, and I do monthly evidence and safety updates for all the clinicians as well. Polypharmacy reviews, I've mentioned those. Upskilling staff, so I've liaised closely with the healthcare assistants and the nurses about the clinics that they do, expanding the role of the HCAs, running joint clinics, and knowing when that they can refer to me if any patient's not controlled with whatever they're reviewing. Effective working across the interface, so working with the district nurses and hospitals and the nursing homes. I'm there as a point of contact. Active signposting, which I'm sure you'll probably come across today, but that's referring to other services instead of our GPs for appointments. And clinical governance, of course, is better in the practice now. Care homes, MHRA alerts, pharmacists can look after, how we deal with uncollected prescriptions, safeguarding, high use of benzos and opioids and how we manage them ordering prescriptions last thing on a Friday afternoon. And I suppose so what, I've mentioned it already, significant workload shift which has led to an increase in morale for the GPs. A quote from the doctor last time I was here was, "I cannot overstate the benefit the practice pharmacist had on our whole team's morale." They were quite getting down in the dumps about the amount of admin about prescriptions that they had to do and the admin staff as well about some of the things they were doing. Reception have got an extra outlet and are being upskilled. Nurses have got more support with prescribing and guidance, especially those nurses who aren't prescribers. Patients, of course, benefit. They're getting their prescriptions quicker. They're getting a phone call with the most appropriate professional. So if it's about medication, they speak to the medicines expert. Prescribing is getting safer because it just is with all the things that I've implemented. And the patients have got longer appointments with me because generally they've got more complex needs. Equally, as of the 1st of March this year, our GPs have gone on to 15-minute appointments from 10-minute appointments. As much as I'd love to stand there and say, yeah, that's due to me, it wasn't solely down to me, but we've got 2 very good advanced nurse practitioners. We've got myself, and with active signposting and all the admin time saved with what I'm doing as well, we're now getting the GPs on 15-minute appointments. The future for our practice, we're looking at getting a pharmacy technician to help with some of my admin, and actually that'll release me to see more patients. We're doing more cluster working with other surgeries nearby that have got pharmacists there. We're going to be having community matrons, which will be supporting with the frailty for the GP contracts. The GPs have recently asked me to start looking at more patients for QOF, RA, CHD, LD, and because of that, they're giving me more hours, so I'm actually going to be there 40 hours a week rather than just 32, and that's starting real soon. Just really quickly, my top tips: have a role in mind for the pharmacist before you get one. Continuity is key, in my opinion. I think a pharmacist does need to be there most days in a practice to have an impact, so staff know where they are, staff can refer to them every day. Increase the pharmacist role visibility within the practice, maybe posters or leaflets to let the patients know who they are and what they can do and when the patient can actually refer themselves to the pharmacist in the surgery. And it is a patient-facing role. Pharmacists are good with patients. We know what they do with medications that they don't tell the doctor. We're good at holistically looking at everything in total. You'd be wasting the pharmacist if they're locked in a back room just dealing with telephone and prescription queries all day. It should be a patient-facing role. And again, I'm one pharmacist in one practice. There are hundreds of pharmacists, soon to be thousands of pharmacists going out there, and they'll all be doing equally good work as this. Well, I work almost full-time in a 15,000 patient practice, and I'm just about on top of the workload there. If there was a pharmacy technician as well, could release a lot more time. It'd be easier to upscale. I think, was there 30,000 patients looking at with the new bids?
Yes, yeah. So the new NHS England bid is looking at 1 pharmacist per 30,000 of the population. Which in itself is primary care at scale. From looking at the pilot programme, it really varies. So you can have a population where you have a whole-time equivalent pharmacist in about 10,000 practices, but also up to 23,000 as well. So it does really vary. We are doing some work with the GP deaneries at the moment, as well from a Health Education England perspective, and with the primary care directors at HE to support practices that are non-training practices as well, to help with the supervision and network arrangements and to understand what the pharmacist can bring and that care redesign element to it as well. I totally agree. I think it's basically around interview and actually application process where you will actually understand what that pharmacist is. We all know that when we're interviewing for nurses or healthcare assistants, we look at the overall picture and what that person can bring to the surgery. So it's a really valid point. As part of the education and training program for the pilot, there is personal development plans. So you will understand where you're good at, where you need improvement on, and what your next bits are to go away and do further CPD, etc. if you need to. This has been happening for over a decade in some surgeries. We know, one of my good friends is a partner in a surgery for the last 10 years. What we've been trying to do now is get pre-regis, so pharmacists that are currently through their undergraduate degree, they do 1 year of training to make them accredited as a pharmacist. We're getting pre-registered, starting to rotate in general practice, as well as in community and in hospital, to sort of develop a pharmacist that has professional mobility across the workforce interfaces. As well as that, now we're starting to see undergraduate schools link in with the medical schools and nursing schools to have interprofessional learning together from an undergraduate level. At UCL School of Pharmacy, where I'm an honorary lecturer, we've started to develop a rotational model for the Bromley by Bow Centre, where they've actually getting their undergraduate pharmacists to learn alongside the GPs, junior doctors and F1 and F2s actually on a rotational placement. And actually we're seeing some really great positive working, and you can see the different sort of skill sets that they all bring and how they can work collaboratively together. So I agree, I think to try and get some of that behavioural change happens, we need to get it done a bit younger as well. So I think there is in the place, but obviously we're flying at the moment with the number of pharmacists we're trying to push into primary care. But I agree, it needs to be addressed, most definitely.
As part of the development plan that was mentioned, one of the big ones is around reporting of incidents, and that is part of every pharmacist development plan, improve the reporting of incidents within the practice. So over the first 18 months, certainly that should be achieved in most of the pilot practices. With regards to individual things, it depends on how the practices run generally, but you know, the pharmacist, myself, I'm invited to all the practice and clinical governance meetings where things are discussed. So we're all made aware of those within the practice. And of course, the first person to look at, if it's medicine related, is me, and say, is there anything we can do around this? And it might involve an audit or a bit of QI to see what exactly is going on and whether any change that we've done has made a difference.
I was very mindful of that because I'd done a federated model in Islington before I joined NHS England, and I totally agree it can be very light on the ground sometimes from an operational management perspective. So with that, we've commissioning an in-practice development programme, as well as the education and training and the independent prescribing. And it will be a set programme sort of working up the specification as we talk at the moment around the support for those pharmacists that are working across multiple sites around care redesign, how they manage their time, how do they support the senior pharmacists to organise and that operational delivery across the federation as well. So as part of the senior pharmacist training pathway, they'll be taught about leadership and management, there'll be operational development, but also supervision training as well, so they're able to support the clinical pharmacists, which will therefore alleviate the amount of time required from a practice manager's perspective, but also from a GP's perspective around the supervision and management on a day-to-day basis. And as these pharmacists mature across the pathway, we'd hope that there will be less onerous within the practice staff and less, just general day-to-day operational stuff, really.